Hello, everyone, and welcome to this week's edition of Got a Problem with Your Knee? Ask Dr. P. This is a live Q&A session done every Wednesday morning at 9 a.m. on Dr. P's School Games channel. That link is in the description below. Now, who is Dr. P? Dr. P is a residency-trained orthopedic and sports medicine specialist, as well as an expert in regenerative medicine. He is here to answer all of your questions about knees. Dr. P also created the Knee Repair, Not Knee Replacement program, a groundbreaking program that allows people to avoid the need for knee replacements entirely. Today, Dr. P is specifically talking about meniscuses, meniscus tears, treatments for menisci, all sorts of things just like that. So what we're going to do is cut right into Dr. P talking about the meniscus, how different tears can cause the need for surgery, how different pieces of the meniscus, different parts of the meniscus can have worse blood supply compared to those that have better blood supply. Be sure to submit your questions in advance every Wednesday. You can do that on YouTube, Facebook, TikTok, Instagram, or on our School Games channel. Again, that link is in the description below. Without further ado, here's Dr. P.
It may heal on its own or with some help with like PRP or bone marrow cells, regenerative medicine therapies. But if it's more than a centimeter and it's all the way through, usually we have to go in there surgically, but we can repair it with stitches. We can put stitches across there and it's got a good 80 to 90% chance of healing. Now, if we're doing an ACL at the same time, it has an even higher rate of healing because we're stimulating more of a healing response. And if we add regenerative medicine techniques like bone marrow, which has stem cells and other cells to help the stem cells, PRP, platelet-rich plasma, which has growth factors, kind of like Miracle-Gro, laser, which increases blood flow. All those things can help increase the rate of healing. Now, if it's torn along the junction between the inner 2/3 and the outer it still has a pretty good chance of healing. We call this is the red zone, meaning there's a lot of blood vessels there. The red-white zone is the junction between where the blood vessels are and no blood vessels. And if we suture that, sometimes these blood vessels will grow back in there and it'll heal. However, if it's in the completely white zone where there's no blood vessels, like in here, you can put all the stitches in the world. It's probably not going to heal, especially as you get older. If you're younger in your teens, maybe you still got a shot because you have a better blood supply. So those are straight up and down tears, quote, clean tears. If you have a tear that goes completely across here, called a radial tear, that's a problem. Those are very difficult to get to heal. Maybe you can get this part to heal, but the part in the white area is very difficult to get to heal. So sometimes we got to trim out part. We call that a partial meniscectomy and repair the rest. If it's a piece that's shredded or like this piece tears and it's flopping back and forth, locking your knee up, and it's what we call a flap tear. It's only attached here at the base and it's flipping back and forth. Sometimes you just have to trim that out and take it out. But we try to preserve as much as we can because, again, it's your main shock absorber. One final thing, if it's torn completely across here, it's going to gap open just like on a barrel. You know, when you have those rings around a barrel, and if you snip that band around the barrel, it's going to pop open and it's not going to provide any support. So if you have a radial tear, that's like snipping that band around the barrel, and it's going to be useless. So you can have all the mass of the whole thing might be here, but there's a tear here. Now it's not functioning. So it's not functioning like a shock absorber anymore, and more force is going across here. So those are really bad tears to have. Whereas if you just strip some of this out and you still have what we call the hoop strength, the hoop around the barrel, if you just strip the upper thirds or 2/3 of a hoop around a barrel, but you still have the lower third or part of it still there, it's still going to hold. It may not be as strong, but it's still going to hold. It's still going to provide to hold that barrel together. So we call it hoop strength as well, is what we call it. And if it's cut all the way across, what we call a radial tear, you lose all your hoop strength and you lose the function of the meniscus. So those are really bad tears to have. So we're pretty aggressive nowadays, really trying to repair as many tears as we can, trying to add regenerative medicine techniques to improve the healing rate. Rehab protocols are much better, as you know. to try to get these things to heal. And because once you lose it, we don't have any way of growing this back. We can grow back some of this. We can't grow back any of this yet. We don't really have any ways of doing that. We'll get there, but we're not there yet. So we really want to preserve that meniscus. So repairing it, adding regenerative medicine techniques, adding laser, having really experienced therapists who know how to rehab these and not let it tear, because it's going to take a good 8 weeks to get that thing to heal, and that's going to take 3 or 4 months to get back to full duty activities after a repair. And you're going to be limited with a brace for a while. 6 to 8 weeks, 4 to 8 weeks, depends on the tear. So there are limitations, and it still might not heal. So 1 or 2 out of 10 don't heal. We think we can maybe get that to 1 out of 10 if we add all these other techniques in there, but still a certain percent aren't going to heal and might need another surgery.
Gotcha. Okay. What's the difference between a torn meniscus and a degenerated meniscus?
Yeah. So that's like bourbon and whiskey. I love this. This is so. All bourbon is whiskey, which is grain alcohol made from grains.
Right.
Bourbon just happens to have at least 50% corn. But anyway, so all bourbon is whiskey, but not all whiskey is bourbon. You can have Scotch, you can have Irish whiskey, etc. So all degenerative tears or flap tears or whatever, they're all tears. It can be frayed, it can be shattered, it can be a nice, quote, clean tear. That's still a tear. A degenerative tear is a subset of tears. Okay, so it is a tear, but it might be just more frayed and kind of, your cartilage can wear down over time as you get older. Mm-hmm. Well, your meniscus can wear down over time as you get older. And so it's technically torn because it's frayed and those are all little small tears, but it's not an unstable tear that needs surgery. So that's a great question. Most degenerative tears do not need surgery. If you're not having mechanical symptoms, your knee's not locking, it's not catching, it's not clicking, it's not swelling and staying in pain, even if it is swelling and staying in pain. If you don't have mechanical symptoms, a lot of times it does not need surgery. We can get it better with our knee repair, not knee replacement programs.
Gotcha. All right. So if someone, I'll read the exact question. Someone submitted, I believe this is on TikTok. They said, my knee has a click or a clunk. What is it?
Well, that can be a lot of things, a lot of things. Do we have another hour for that question? Okay, that can be a lot of things. And I'm just going to try to go through as many as I can think of. So number one, it can be mechanical. It can literally be you have the cartilage should normally be nice and smooth, okay? Kind of like a pool cue ball or ball bearings. And normally it's nice and smooth and it just, you don't have any noise, none of that stuff. Well, when you start getting this wear and tear, it's not always a big one like this. You might have several kind of smaller ones. So it looks more like the surface of the moon. So now imagine you got a bunch of craters and these craters are rubbing against each other and they can click, snap, and pop. So just that mechanically can make noise. The lining of your joint, the synovium, our joints have a lining and it's called the synovium. And if that gets inflamed, it gets kind of fluffy and that can make pops and snaps. I mean, even like, you heard of cracking the knuckles, there's a thing, nitrogen gas. I mean, theoretically, your knee can pop and snap from that as well. But a lot of times the popping and snapping we hear most commonly comes from wear and tear under the kneecap, because when you're bending and straightening your knee, that kneecap is articulating with this bone here, and especially if it's starting to wear down, it will make noises. But there's another thing, the lining of your joint can get inflamed and swell, but the lining of your joint can also have some thickenings in it. They're called plica. So the most common plica, which isn't shown on this model, starts on the kneecap and comes right across here. So it'll, as your knee bends and straightens, that plica will snap, snap, snap. You'll hear it. You can have something loose floating around in there, which can snap. A meniscus tear can snap, clunk. You can have a torn ACL, and so then your knee is. We talk about that pivot shift test, but when you have a torn ACL and you go turn the opposite direction, you can get a clunk where the knee kind of pops out of place and then clunks back in. So clunk is probably it's all semantics, but when someone says clunk, I think more instability, like ligament problem. I may be wrong on that, but clunk is more like the bones are physically kind of getting out of place and then clunking back into place. Clicking and snapping is more Could be wear and tear, could be inflammation, could be, I mean, even when you get excess fluid in there, that can make noise, you know. So there's so many things. I mean, what do you got? You probably, what other things can you think of? Allison, you're behind the camera. Anything you can think of that causes snapping, crackling, popping? There's a lot of different things. So
yeah. Well, I think parsing that out a little bit, right? Talking about meniscuses and talking about all the different things that could come from a click or a clunk, right? Because that's a a patient reported thing, less than objective,
just objective.
Right? Yeah. So something that you do hear with meniscuses quite often, though, outside of clicking and clunking, is locking.
Absolutely.
Right? So one, what is that locking? And two, what can be done if a knee is locking?
Yeah, super question. I tore my meniscus. I was getting those feelings, so I know exactly what and it was clicking. But what that is just imagine a piece of this tears, but part of it's still attached. Or there's another thing called a bucket handle tear. People, I got a bucket handle tear in my meniscus. A bucket handle tear is a pretty big tear usually because it will usually span all the way from the back, comes all the way across here, and then that piece that's torn. So imagine I cut this right here, and then that piece flips in like a bucket handle back and forth. So if it flips here, it's going to get in the way of you being able to straighten that knee. So if it flips over here, you're not going to be able to straighten your knee. It's going to be locked up. So to get it unlocked, sometimes you got to shake the knee to get it unlocked, and it'll flop back into place. But these bucket handle tears that are huge, they are very difficult to get to flop back into place on your own, or even if I try to manipulate the knee, numb the person up, try to manipulate it to get the flop back in place so it's not locked. Very difficult. Whereas a flap tear, so if there's a tear that it's attached here at the base, but it comes all the way across here, and the piece just kind of flips in and out. That will lock up, but then you can usually shake your knee and it'll unlock on its own. A loose body, something loose in the knee. So if a piece of meniscus tears off, or a piece of cartilage tears off, or a piece of bone chips off, a bone spur, and it gets loose inside the knee, it'll float around. They call them joint mice because they float around the knee. If that loose piece gets in between these two bones, it's going to lock your knee. It's going to hurt like heck too. That one, a lot of times people will literally say, "It feels like something's floating around in my knee," or it'll float around all over the place. So they'll sometimes feel it floating around right here, and then it'll go away, or feel it down here. So a lot of times a loose body, something that's loose floating around there, they'll feel it every so often right underneath the skin. I can feel this thing moving there. Whereas a meniscus, you're not going to usually feel that moving all around your knee. You're just going to feel it along kind of the joint line or kind of deep inside. That's pretty much why you would get locking. There are people who say they're getting locking a lot of times. When you say, "Hey, is your knee actually getting stuck in a bent position and you can't straighten it and you got to shake it to get it free?" That's locking. Sometimes people will say, "Yeah, my knee locks straight." That's usually because of pain, or even like, "I can't bend it." Well, because you can't move it, or because of pain. And a lot of times it's pain. So they'll say locking, but you really gotta ask them more questions to figure out, is it really truly locking? Because if it's truly locking, it probably is going to need surgery. It's hard. You can't just inject bone marrow cells in there and unlock something, or they're not going to dissolve something that's loose floating around there. I need to go in there arthroscopically. I'm still a surgeon. Little arthroscopic poke holes and minimally invasive, and get out that thing that's loose that's floating around there, or take out the torn piece of cartilage, or repair the torn piece of cartilage, because we always want to repair if we can do it. Then the bone marrow and the PRP can help that repair heal. Even if they have a loose body and we take the loose body out, well, what caused it? Was there some arthritis or something in there? We can still, after the fact, do a lot of these regenerative knee repair, not knee replacement techniques, but sometimes surgery is needed.
Yeah. What are some ways that you would be able to differentiate between if someone needed surgery versus, someone that could use some of these minimally invasive techniques? Like, how would that patient be worked up? What should the expectation be of that learning process and figuring out exactly what's going on?
I mean, great question. So number one, you always want to take time and listen to the patient. We talked about subjective. That's like what you're telling me. What you're telling me is huge. I can already probably 80% of the time figure out what's going on just by what you tell me. Mm-hmm. Like, I was skiing, I cut around a mogul, I felt a pop, now my knee's locking up. Well, that's an acute injury, meaning it just happened. Your knee's locking up. It's probably a meniscus tear. It could be your ACL too, but you might have said, well, my knee didn't really swell up that much. I felt a pop. I was able to finish the rest of the day. But then later in the day, when I was in the bar drinking, my knee started to lock up. And so I fell down and it hurt. And then I went to the ER and they said, oh, your x-rays look fine. You're fine. No problem. Well, that's probably a meniscus tear. Whereas if it's and age makes a difference there too. But that's one thing. Or it might be someone, hey, I don't know what happened. All of a sudden, my knee just started swelling, and then you get more history. Well, what have you been doing anything lately? Well, yeah, I was walking my neighbor's dog. They've been on vacation, so I've been walking more. I've had to kneel and clean up their poop and whatever, and so maybe that's a flare up of arthritis. They're not. Are you having any locking? Nope, I'm not having any locking. It's just swelling and painful, and so history is huge. Is this chronic, meaning it's been going on for months and years? That's more of a degenerative, usually wear and tear. Or is it more acute? That's more of an injury, probably something's torn. Or it could be a little bit of both. And so the history is really, really important. The physical exam is extremely important as well. I've done some posts on how to examine, for a meniscus tear. We examine, along the joint line. The joint line is between the thigh bone and the shin bone on the outer side, and on the inner side, you can feel a little V right here when we're examining somebody. And so you feel the thigh bone, you feel the shin bone, and you feel in this V, and that's right where the meniscus cartilage is. And if you have a tear of your meniscus, it is going to hurt on here. Now, if you've also torn this ligament, your MCL, sometimes that'll hurt as well. So you gotta really, physical exam is important, because if they only hurt along here, and they don't hurt here or here, it's probably more likely the MCL. Not that you couldn't have a tear of your meniscus there, but we know most of the tears are back here, actually, technically. You can still have them here and here, but they're most commonly here. Now, if they have tenderness only here and not here and here, that's probably a meniscus tear. We can also do what we call a McMurray test, where we twist and turn the knee in the bent position. And if you bend that knee, you can see this is pinching this meniscus between these two bones. And if there's a tear back there, you're going to have pain. So that's called a McMurray. So the physical exam is really important. If we're going to do a Lockman on somebody, where we pull the shin bone forward on the thigh bone, that's going to tell us if they have an ACL tear, or what we call a pivot shift test. Or if we're going to test for a tear of the MCL, the medial collateral ligament, we're going to put what we call a valgus stress. And if it opens up like this, you're pretty sure you got a tear of your MCL. So the physical exam is hugely important. I can't tell you how many people, they come to us and they say, wow. And we're like, well, what do you mean, wow? Well, you're the first doctor who's put your hands on me. I'm like, well, how do you figure out what's wrong with someone if you don't physically examine them? That's what we go to med school for. That's what we do our residency for. But because of the way the system is nowadays, and doctors don't have a lot of time, and the insurance companies force that on people, they don't sit and listen to the patient. They don't take the time. They don't examine the patient. They just look at the x-rays. Now, the x-rays are important, or the MRI is important, and we look at those as well, because if there's a loose body floating around in there, something loose and it's made out of bone, you're going to see it on the x-ray. If there's arthritis, you're going to see that much better on x-rays than you are on an MRI. If it's a torn ligament or meniscus, you're going to see that on an MRI. You're not going to see that on an x-ray. If it's stress or microfracturing, little soft spots in the bone, you're not going to see that on an x-ray. You're only going to see that on an MRI. So a lot of people say, doctors will say, you don't need to get an MRI on someone who has arthritis. Their cartilage is wearing down. Well, yeah, you do, because you can't see what's going on with the underlying bone. You can see on an x-ray that the cartilage is wearing down because there's no space there. But you can't see if, when that cartilage wears down, now more and more force is going to go transmitted to the bone. And bone, actually, if you look at this is real bone here. This is a shin bone. It's hard on the surface, but under the surface, it looks like coral. It's porous. And as this cartilage wears down, more and more force gets transmitted to the bone underneath, and the bone can start to break down faster and the body can heal itself. You can get little stress or microfractures, which you cannot see on an x-ray, but you can see them on an MRI. They look white on a black background. And if they have those stress or microfractures, they are 9 times more likely to go on to need a knee replacement. The cool thing about the stress microfractures is they are treatable. We can heal those. We can fix those. We can inject good bone marrow cells into where the bad bone marrow is, and we can get it to heal. So that's kind of a big part of knee repair, not knee replacement. And I was talking about, you're not going to be able to figure all this stuff out if you only spend 7 minutes with a patient. The average time in the US that people spend, doctors and medical providers spend with a patient is 7 minutes. I can't get your history in 7 minutes.
Right.
Do a great physical exam, look at your x-rays, explain it to you, look at your MRI, explain it to you. Matter of fact, you can't get all that done in one day. Like that'll take 4 to 6 weeks. It may take months to get all that done sometimes. Here, because we don't have the restraints of the insurance companies, we can do all that in one day. We can get all that done in one day, which is a major time saver. People are busy, they have work, they have kids, they have dogs, they have parents, whatever they're taking care of. We can get it all done one day. People really, really appreciate that. But we will spend the time. We'll spend an hour listening to what you have to say. We'll examine you. We'll look at you with an ultrasound, which we didn't even talk about that. We can look inside the knee live with an ultrasound. We'll look at your x-rays. We'll get an MRI that day. We'll get a report. We'll go over it with you. Then you'll get a full body exam because we're talking about the knee, right? Mm-hmm. But the knee is connected to your hip, your ankle. All these things are connected. Your upper body affects your lower body. Your core affects both. So someone like you, a BFit expert who we have, all have medical degrees. You're a certified athletic trainer, but you're also a strength and conditioning specialist. So you're going to look at the entire body and, oh yeah, your knee is bothering you, but guess what? Because your hip is tight and your ankle's tight, that's why your arthritis is flaring up. If we start taking care of those as well, that may help your symptoms in your knee. And so we're going to do that. That's going to be another hour. Then we're going to all meet together as a team. Then I'm going to sit down. I sit down with the patient again for another hour, sometimes an hour and a half, to figure out what their goals are. Because how do you figure out how to? Some people might want surgery. Some people might not want surgery. Most people don't want it. But you have to figure out, like, sometimes you might need to do surgery. Most of the time we try not to, but even then, what non-surgical program are we going to do? How long is it going to take? Well, that all depends on what you want to do, what your goals are, not just what your diagnosis is. Because we have tons of people who have arthritis. It's a very common diagnosis, but if someone who has arthritis wants to walk their dogs and sleep at night without pain and not bother their spouse, or someone wants to play pickleball, or someone wants to run a marathon like you're going to do someday, those are all different goals, and those are all different programs using the same principles.
Yeah.
So you can't do it in 7 minutes.
Exactly, and it's really good for the people who are not wanting to have continued knee pain for 4 to 6 weeks while you wait for the MRI to be approved. Like if you're a person that says, I need to get this figured out now, that's a perfect setup, right?
Totally agree. A lot of people ask that question. Yeah. How long? I get questions on how long does it take to get this? Or I took, my doctor saw me and I got x-rays and they won't do an MRI, or they said the insurance company won't let me do an MRI. That's the problem. The insurance company, I'll just give another personal example. My wife, her OB/GYN ordered some medication for her. The insurance company just denied it yesterday. And, that's so frustrating. Yeah. And the doctor's not in charge of her care. The insurance company is.
Right.
I hate insurance companies. Sorry.
Yeah. True. For sure. So that's a great example of how you could, work up a meniscus, or kind of differentiate what's going on in the knee overall, right? So let's talk about treatment a little bit. So, should someone with a torn meniscus, let's just say generally, let's just say they maybe haven't had surgery yet, and maybe we can compare that to if they have surgery, should they wear a knee brace?
Yeah, great question. In general, we would never prescribe a knee brace for someone who has, quote, just a meniscus tear, because their knee isn't unstable. If they have a torn ligament like an ACL or multiple torn ligaments, a brace may help, especially if they have an MCL tear. If you brace them and you rehab them right, this will heal. This thing will heal without surgery. 9 times or more out of 10, even a bad tear. David Montgomery for Detroit Lions, right? Oh, he's going to need surgery. He's going to need surgery. He had this tear. No, he didn't need surgery, and he's going to do just fine. So most of the time that doesn't need it, but a brace would help that a lot. For a meniscus tear, a brace is not going to be necessary. As a matter of fact, it might even inhibit things. Braces will inhibit your muscles, and we know our muscles are our main shock absorber, so you get some atrophy, some weakness in the muscles from the body, your muscles relying more on the brace and taking it easy. We'd rather have you get in to see someone like you and strengthen those muscles. That's going to take the pressure off the torn area and the injury, and it's also going to make you recover faster if you need a surgery or if you need a procedure or you go into a program. So I'd rather have somebody strengthen their muscles as opposed to get a brace if they don't need a brace. And if you have a torn meniscus, you don't need a brace. A brace isn't going to help at all. Also, braces, people, they come in, they get all these braces, knee sleeves, and some people it affects their skin. They get skin irritation. And if you need surgery or procedure and you have like little zits and pustules and stuff, heat rash, whatever, that's going to increase the risk of infection. We don't want that.
Absolutely.
Also, you wear a brace, you're not going to bend the knee and straighten it as much as you start to get some stiffness. Stiffness isn't good. If you have a problem under your kneecap and your knee's getting stiff, that's just going to grind this kneecap into here harder, and you're going to have more pain. So getting that full range of motion is important, and a brace can sometimes inhibit that. So in general, we don't prescribe braces, but if someone feels as though they just feel it makes their knee a little warmer, like a knee sleeve, and it's not inhibiting their range of motion, their skin's not having an irritation to it, they're still seeing you, I'm okay with it, but in general, I'd say no.
Gotcha. So in terms of, the surgical route, we did have a question. Someone said, should someone over the age of 65 get surgery for a torn meniscus? So there's a couple of pieces to that, but.
Well, it depends on the type of tear again. So if someone's 60, so we get the opposite that happens sometimes too. The patient will go to their primary care doctor. The primary care doctor will not even order x-rays. They will just go straight to an MRI, or they might have to send them to physical therapy first, and then they get authorized to do their MRI. And then they get the MRI, and the radiologist reads it as a meniscus tear. But we know all tears are not created equal, right? And it might even say degenerative meniscus tear, but a lot of times the primary cares, they just see tear, and the patient sees tear, and they're like, I need surgery.
Right.
But if they're not having mechanical symptoms, it's a degenerative tear, it's more of an arthritic degenerative process, we almost never operate on that. And actually, there are plenty of studies that show that we'll just say PRP, platelet-rich plasma, which is taking your platelets, which are part of your blood, spinning it down into the
centrifuge right
here, separating out the platelets. The platelets have growth factors, and injecting those into the knee. And there's at least 37 studies, high level 1 and 2 studies, 1 through 5. 5 is the lowest, 1 is the highest. 37 level 1 or 2 studies that show that PRP, just PRP by itself, not all these other things we're talking about, which also add to it, but just PRP is better than cortisone, hyaluronic acid, gel injections, standard physical therapy, and even surgery for like degenerative meniscus tears, arthritis. So there's a lot of studies that have shown that PT can get a degenerative meniscus quote tear better without needing surgery. So those people don't usually need it. Now, if there's not a lot of arthritis and they had an injury, maybe playing tennis, because we had a tennis coach and she injured her knee in her 60s.
Yeah.
And she didn't have much arthritis on her x-rays, even on her MRI. And she had an acute injury, an injury that just occurred, and she was getting mechanical symptoms. And her MRI showed a quote clean tear, not a degenerative tear. So I went in there surgically because she was having locking. Mm-hmm. She hardly had any arthritis. We repaired it. And we've had several of these people in their 60s. We repair it, and then we'll usually do PRP or bone marrow as well, because when you're in your 60s or 70s, you definitely don't have as good a blood supply or healing ability. Right. So we try to bump that up. And so rather than, probably if you're in your 60s or 70s, it might be 3 out of 10 don't heal. Okay, still a good chance it's going to heal if you follow the protocol and you do all the right things. But anything we can do to increase that, like adding laser, adding PRP, adding bone marrow cells, I pretty much always recommend that, if it's especially in that age category. If you're 16, that thing's probably going to heal. Well, the reason that won't heal is because those people 16-year-olds don't always comply with what we want them to do. That's why. But healing-wise, they have an amazing ability to heal. 60 or 70, absolutely we can do it if it's the right type of tear, and we do that. We've done it on plenty.
Yeah.
And then people want to stay active. And why would, the fastest growing group of population in the U.S. is 80 plus. Yeah. So if you're 65, you still want to play pickleball for another 15 or 20 years, right?
Right.
So go for it.
Yeah. Keep playing pickleball.
And tennis and racket sports have been shown to people who play those sports live longer. So we definitely want to get them back playing.
That's it.
Like tennis average is 9.7 years longer than average. People live 9.7 years longer.
That's interesting.
Yeah.
All right. I gotta start playing tennis.
Yes.
So we talked about pickleball and tennis, right, being good for at least aging. correlation.
Right.
But is walking good for a torn meniscus?
If you have a torn meniscus that is causing mechanical symptoms, you're probably going to need surgery anyway. I mean, just walking in and of itself isn't going to necessarily be bad, but it's not necessarily great. So you have to do your normal daily activities, and that's fine. Walking for exercise, if you're not having any mechanical symptoms while you're doing it, just walking straight ahead, is probably not terrible. It kind of depends on how the person's doing. However, things you don't want to do are cut, pivot, run, jump, pivot, because that's going to be more prone to you make that tear worse, or even lock your knee up, and then you might need more emergent surgery versus elective surgery if we can't get it unlocked because it hurts.
Right.
And then squatting and kneeling would be bad. That can make that tear worse or make it lock up. So just walking like straight ahead, not running, not cutting, not jumping, is probably fine if you can tolerate it. But some people, like when I had my tear, even walking, I just remember walking to the office and just straight walking, my knee would lock up. Riding a bike, I couldn't ride a bike either because it would lock up. And you think, well, bike should be great. So sometimes there's a piece, even swimming or whatever, if there's a piece flopping around in there, it doesn't matter what movement you're doing, there's a chance it might flop into the wrong spot and hurt. Right. And so it kind of depends on what people's symptoms are. So we do try to, if someone's getting mechanical symptoms, we want to try to get them fixed as soon as possible because you don't want that tear to get worse. And here's another example. I had a woman who played in a professional football league. We had a professional women's football league in Syracuse in the past. She tore her lateral meniscus, a big tear. I think it was even a bucket handle tear. Oh, and she was tough as nails. And she's like, I'm gonna finish the season out. It was like the third game of the season. They still had 2/3 of their season left. I think they went to the playoffs. And after the season was over, and she was having issues and pain and swelling, but she sucked it up. And so after the season was over, we went in there to do the surgery, and that piece that had flipped over was rubbing abnormally on here and caused a groove in her cartilage. It wore down her cartilage, and that wouldn't have happened if we'd fixed it quicker. And so it wore down her cartilage, and guess what? Over time, she eventually, that became symptomatic, the arthritis part, and we weren't able to repair it either because it had shredded after all that time. So in other words, you might make a tear that's repairable, unrepairable, and then we have to trim it out and you lose all that shock absorber. So it's better to do it sooner if you can. Yes, there's people who can't for varying reasons, and in her case, she knew the risks and benefits. She wanted to finish, and she has gotten gel injections and all kinds of other things over the years to help with the arthritis.
Gotcha. In terms of heating and icing, is heating good for a torn meniscus?
Well, I would say, again, if it's an acute injury, it just recently happened, for sure, at least the first 3 days, icing's better. And probably even for the first couple of weeks, icing is better because it decreases swelling and inflammation. And it helps with pain too, frankly. It kind of numbs the knee up a little bit. Mm-hmm. Heating or icing isn't going to do anything necessarily to make an unstable meniscus tear heal at all. It's more about how it feels. After 3 days, especially definitely after a couple of weeks, heat or ice, whatever makes it feel better. Heat is sometimes better at that stage to kind of warm it up and get some blood flow going in there. Mm-hmm. And if it is a very small peripheral tear, heat could increase the blood flow a little bit and maybe help with healing. So there is a little benefit possibly there. But I mean, I think laser would do even a better job without having to put heat or ice on it to increase the blood flow and try to get that very small tear that's in the periphery where the blood supply is to heal without surgery. And frankly, a lot of times we'll do PRP and bone marrow on those ones as well. So there's certain types of tears we can get to heal without needing surgery. But no, I wouldn't say ice or heat is going to make a meniscus tear any better or worse necessarily. It's only going to help your symptoms. And early on, ice is better. Later on, heat is technically probably better, but ice or heat, or some people will do both. They might warm it up in the morning with heat to get going, and then by the end of the day or when it's sore and swollen, they'll ice it.
Okay, gotcha. So you talked about laser a little bit in there. What What would be the benefit of something like MLS laser? And is that similar to heat, or is it a little different?
Yeah. So MLS stands for multi-wave lock system. So it's more than one wavelength. There's certain wavelengths of light between 600 and 1200 nanometers if you want to get geeky, or 1000, that can penetrate through our skin and can stimulate the mitochondria. So any of you out there who remember from high school biology what the mitochondria is, it is the powerhouse of the cell, kind of like the battery of the cell. So the laser energy, the certain wavelengths of light, can stimulate the mitochondria to produce more energy, more ATP, which helps with healing, number one. Number two, decreases swelling and inflammation. We were just talking about swelling and inflammation, how ice can help make that go down. Well, laser can help make that swelling and inflammation go down as well. Increasing blood flow. We were just talking about that. Heat can maybe increase blood flow, whereas ice constricts blood flow. Mm-hmm. So laser also increases blood flow to the area, which helps with healing. We talked about analgesic effects. Ice, even heat can make your pain feel better, right? Sometimes, depending on what the problem is. Same thing. Laser has a direct pain relieving effect. It inhibits the painful nerve fibers, the nociceptors that cause your pain. MLS is a particular patented brand with two wavelengths, 808 nanometers and 905 nanometers. 905 is a little bit more for the pain, 808 is a little bit more for the swelling and inflammation. And it puts them together in a patented locked fashion where, interestingly, there is no heat generated. You think of laser like going to burn something, right? You're going to blow, a laser blaster on Star Wars or something like that. And there are lasers that are beneficial, but they generate heat. If you hold them there too long, literally, there's lasers for human use that if you just left on the table on, it would burn a hole in the table. Mm. We don't like that. I never liked that. I always loved the fact that lasers can help people heal, but I wanted the safest one. So what we use is called an MLS laser, and it's the safest laser out there. You can shine it on somebody all day long, and it is not going to burn them. Yet it is just as powerful as the most powerful laser. It's a class 4 laser, which is the most powerful laser. So it'll get deep. It'll go 4 to 6 centimeters deep. And so the laser does not generate, the one we use. Now, there are lasers that do generate heat, so you have to ask your provider who's using what kind of laser they're using, or you might see them moving it around a lot faster because they don't want to burn the person. Right. But ours, it's a robotic head. It will go back and forth, up and down, so it can treat a wide area. And then you, as a technician, laser technician, expert, can take the handpiece and try to get into the little nooks and crannies. If you need to get into that meniscus, you can aim the handpiece from the outside and get in there where you really want to get that to heal. So we use a combination of the robotic part to treat the whole area, and then the handpiece. And then we even have what's called an M-high, M-high, right? Yeah, laser. That is the most, one of the most powerful lasers out there. And it just has a handpiece, but it's super powerful, even more powerful than the MLS laser. And we use that kind of to jumpstart getting people going, or to fine tune certain areas. So, and that won't, same thing. That's a system that will not burn the patient. And so we go safety first. Obviously, the biggest concern with lasers is you don't want to shine in someone's eye. Even a laser pointer, you don't want to shine in someone's eye. So we wear the goggles. Absolutely.
So switching gears a little bit, just because I want to make sure that I get everyone's questions. What is calcification of the meniscus? Like, how does that happen, and how is it treated?
Yep. So as we get older, our bodies, we kind of we get certain areas that can calcify, just like you get your hardening of the arteries.
Yep.
So that can lead to heart disease. It can lead to peripheral vascular disease, meaning if your arteries get calcified, they're stiffer, mm-hmm. and they also develop these plaques. Right. And so there's not as much blood flow going through, and that happens as we get older. Well, you can get calcification in other areas of the body, in your cartilages. You can get it in cartilage throughout your body, but the meniscus happens to be a cartilage, as does the articular cartilage. And as you get older, you can get calcification of the cartilage. We call that chondrocalcinosis. Chondro means cartilage, and calcinosis means calcium deposits. Mm-hmm. It can happen to the meniscus. It can happen to the articular cartilage. It's a little more common in the meniscus. It isn't necessarily going to cause pain. You can see it on an x-ray, by the way. And you can see it on an MRI, and it can trick you on the MRI into thinking there's a tear there because the meniscus should be black on an MRI. And when you see white signal or a white line, that's usually indicative of a tear, especially if it goes all the way to the surface. When someone has chondrocalcinosis, it'll show up white on an MRI as well. And so sometimes people can get faked out, radiologists, et cetera, that there's actually a tear when there isn't. So that's one thing. But in and of itself, it isn't going to necessarily cause pain. It probably does affect the load bearing or shock absorbing capability of the meniscus because it's harder, it's more calcified, and it probably makes it more brittle and more likely to tear. Although I don't know if there's any definitive study that guarantees that or shows that. But just mechanically and physics wise, it makes sense. So in and of itself, it's not a huge deal. It's just a sign of aging.
Right.
But you might see it on a report. You might get faked out on an MRI. And when we do the surgery on it, if someone has a torn meniscus and they have a lot of calcification, it does make it harder to trim away and bite away the meniscus because it's harder. And probably negatively affects healing. Again, I don't know of any definitive study that shows that, but you can physically notice a difference when you're operating on a meniscus that's quite a bit more calcified. And as far as the articular cartilage goes, same thing. Probably it's not as, it's not as load bearing. If it's calcified, it doesn't function as well as it should. And you can actually see it too when you get in there. Sometimes you can see that the nice smooth cartilage has these little speckles of white in it, and that's the chondrocalcinosis. So it's more of a sign of aging, kind of like hardening of the arteries, hardening of the cartilages, and in and of itself, it's not going to cause pain as far as I've ever seen.
Okay, gotcha. So we're getting towards the end here, so this is a great capstone question. You as an orthopedic and regenerative specialist, what are you seeing as the new treatment for meniscus injuries? What sort of things are maybe plausible to do now? That's a new treatment, different than what we've done for, let's say, the past 30, 40 years. And what sort of things do you see on the horizon?
Yeah, it's a great question because as a surgeon, especially an orthopedic surgeon, we like to physically fix things. Like go in and sew something together, or go in and put a plate and screws on something, or go in and cut off the end of the bone and replace it with metal, plastic, and cement, a knee replacement. Notice it's more of a resurfacing. We're not cutting the whole knee out. So we've gotten really good at like physically fixing things, but there's a biology there too, and the body has to heal itself. And that's the part that we kind of didn't appreciate as much. And biology, by the way, also has to do with your nutrition. By the way, it's a huge thing. So that is another thing that's coming about. Like surgeons and surgery are finally realizing, hey, we need to optimize this person before the surgery with their nutrition, because you need the building blocks to heal, right? And when you have a surgery, you're going to need more building blocks, more healing. Your body's under more stress. You're going to need you need the right stuff. Yeah. And so nutrition before, during, and after is huge. So that's kind of, it shouldn't be new. Like we knew, Hippocrates knew, let food be the medicine and medicine be the food 4,000 years ago. But it's just starting to become more of a surgical thing. Like it's not just about fixing things in physically, it's about optimizing your biology. So that's one thing. So specifically regarding a meniscus, the hard part of a meniscus was, in the old days, we didn't have arthroscopic surgery. So they had to cut the knee open, make a big incision, and just take the whole thing out. And people did great for a while because there was no locking anymore. But when you lose that shock absorber, you'd wear out and get arthritis. By the time, if you injure your knee playing football in high school, 40s or 50s, you got bone on bone, and you need a knee replacement. Right. So arthroscopic surgery started. We're like, okay, we're only going to trim out the torn part and leave the rest behind. And we used to think, oh, even if there's a radial tear, hey, we're going to preserve this part and this part. We're going to take this hunk out. And they still had 90% of their meniscus. Well, we didn't realize the hoop strength was gone. And even if they have 90%, it's doing nothing. So that's when repairing started. Okay, we got to start repairing these. And repairing was very difficult. When I was doing my residency in the late 90s, early 2000s, you had to make an incision. You had to put like way back here, very difficult to do. You had to put like a spoon back here and fish these huge needles through, and the stitches come through, and then tie the knots. It was very difficult, very time consuming, and a lot of doctors didn't want to take the time to do it. But we knew repairing the meniscus was the key.
Right.
Then all these companies, Arthrex, Zimmer, Stryker, Biomed, all these different companies came up with these ways to repair it arthroscopically. And first, they weren't the greatest. First generation weren't the greatest, but it was a start. Second generation, third generation. Now we have amazing ways to repair the meniscus arthroscopically, amazing tools, techniques, where we pretty much got that down. We really can repair almost any type of meniscus now pretty quickly with amazing tools. So we've got that down. Now, okay, now I can repair a meniscus that's in an area that might not have normally healed. Great, I put stitches in it, but it's not going to heal. What good is that, right? So now we're working on, hey, how do we optimize the biology? And that's where the stem cells, the bone marrow with the stem cells and other stem cells, and even, you can go overseas. We have a clinic that we are affiliated with in the Caribbean, GARM clinic, and it's on the island of Roatan, beautiful. And we can use donated stem cells there, things that aren't available yet in the United States, which I think will eventually. But we can still, right here in our office, we can take bone marrow cells right in this room, right from someone's pelvis, just under the skin right here, numb the skin up. They don't need general anesthesia or anything. And we can inject that in. I like to actually kind of do it a couple weeks after the surgery, because when you do it during the surgery, you have these little poke holes, and all your good stuff you put in there can leak out a little bit. I mean, you try to sew it up as best as you can. But I like doing it a couple of weeks after. So we'll do the surgery if we do a repair. We'll see the person back 2 weeks out. Everything's healed up, looks good. We'll harvest the bone marrow. We'll do the PRP as well. So the bone marrow, or the cells, do the work. The PRP is kind of like the Miracle-Gro to help those cells work better. Right. And we'll inject it in to try to help get that meniscus to heal better. And so I think and then the laser as well. Laser penetrates deep into the knee and increases blood flow, decreases inflammation, helps healing, stimulates the mitochondria. Any, rehab protocols. That's another thing. Like, those have slowly evolved over time and gotten much, much, much better to optimize the rate of healing. And also, again, like, just concentrating on the knee only. If they have a mechanical or they have a dynamic problem with their hip and their ankle that might have led to that knee problem in the first place, why are we not fixing that, right? We fix everything so that they're much less likely to tear the repair, and the repair is going to heal, but then in the long run have it re-tear again, because you could. So the new things are, I think, biology, ways we rehab these people, and the tools and the techniques probably still will even get better. So, but those have improved so much that now it's like, hey, we can repair just about anything. How do we optimize that healing once we actually repair it? Because repair doesn't mean heal. Repair just means we sewed it together. Mm-hmm. It's still got to heal.
You're right.
So that's where all the biology. And frankly, here's one other little thing, by the way. The bear, this one, this is an implant, type 1 collagen implant. It looks like a packing peanut. And when someone tears their ACL, we sew it in between the two torn ends. This looks huge, right? We soak it with the patient's own blood. It gets sewn in between here, and it acts like a bridge to allow that ACL to heal. But what happens is this turns into a hydrogel, and it coats just about everything. So if you have a meniscus tear as well, I'm going to knock on wood here. We have not had a single meniscus tear that we repaired with a bear that we had to go back in and re-repair. Zero. I mean, I'm sure it'll happen at some point, but things like this that we didn't even realize would have an effect on the meniscus it's unpublished data yet, but I think if you ask the bear surgeons, who do a lot of them, they will tell you the same thing. And I think there's going to be data that comes out that something like this will also help. So maybe we inject a little bit of this into the meniscus. I know there's studies being done. I know there's doctors who are doing that. When they do a meniscus repair, they're taking some of this and injecting it as well. And it may coat the area, which allows for healing as well.
Gotcha.
It's a bridge to allow the blood vessels to grow from side to side. So that's another thing that's new.
Interesting. Amazing new treatments. Cool. Focusing on biology, right?
It's only going to continue to get better.
That's it. Well, thank you very much for your time.
Awesome. Thank you.
I appreciate the education for everyone on meniscuses. Yes, I'm using it again just to be a pain. It's menisci, just so everyone knows. I screwed up at the beginning of the video, and now I'm correcting it. Be sure to follow along on YouTube, Facebook. We have a Skool Games channel where you can submit questions and watch these live every week. TikTok, what's your TikTok handle?
Dr. Marc Pietropaoli.
Boom. Instagram?
Same thing.
Perfect. LinkedIn?
Same thing.
Wonderful. So Dr. Marc Pietropaoli, be sure to follow Doc at that.
And
as
then
well as
Victory in Motion. Yeah,
Victory in Motion 1.
Yeah.
It's at Victory in Motion 1. Submit any questions that you have and join our Skool Games channel. For right now, it is free. So be sure to follow along on that. We'll see you next week at 9 a.m.
Thank you all.